It gives me absolutely a great pleasure to introduce our afternoon panel. We're going to be taking a look at the pregnant patients who are presenting for surgery. And our first speaker, and who'll be also moderating the panel, is Dr. Joy Hawkins from the University of Colorado.
Thank you, Bob. All right, getting oriented here. So what I'd like to talk about today is more kind of the controversial areas. I think we've all at some point in our career taken care of a pregnant patient in the operating room because she needed her appendix out or her ORAF of her ankle or whatever it might be. And those cases are fairly anxiety provoking, I think, for most of us. Seems to be a lot of logistics to worry about. So what I want to do today is talk mostly about the controversial areas and let us just re-examine why do we do those things that we do? Why do we believe the things that we believe? So we're going to go through some cases and talk a little bit about our decision-making process for this. So here's your first case. You have a healthy 25-year-old woman who presents to your ambulatory surgery center for knee arthroscopy on an outpatient basis. Does she need to have a pregnancy test? Now, I just want to take a show of hands first. How many people have a mandatory pregnancy testing policy in their hospital? Probably about 50-50, I would say. Okay, so let's talk about that. Let me just start by saying here in a first world country, ACOG reports that at least 50% of pregnancies are unplanned. Kind of a sad statement, but nonetheless, I don't know if you can read the dad here is saying to the mother, and to think the reason we went on that second honeymoon was to get away from the kids. So even under the best of circumstances, not all women are going to know that or be planning on getting pregnant when they present to you. So what happens when you do mandatory pregnancy testing? This was a specialty orthopedic hospital. They initiated mandatory pregnancy testing, and then they looked at the results after 1 year. And what they found is they had tested over 2,500 women. They had 8 positive pregnancy tests, but 4 of those ultimately were determined to be false positives. 3 of the false positives, after a negative serum HCG, so a blood pregnancy test, went ahead and had their surgery. The other, I think, just kind of threw up her hands and walked away. So overall, after that year, they had a little over 1 in 1,000 women who they tested who were true positives and whose surgery was canceled. So the number needed to treat to get 1 actual positive pregnancy test was 647 women, and that means the cost to determine 1 true pregnancy was over $3,000. Is that cost effective? Now, in their editorial that went along with that, they say, well, should a spontaneous abortion occur? Should she miscarry after her surgery? Or should this baby be born with a congenital anomaly? This could be attributed to the surgery or the anesthetic. So screening may decrease litigation, although potential cost savings are difficult to quantify. Well, do we really want to do all our testing based on litigation? And what about this woman's ethical and privacy concerns? This is not an innocuous test. This isn't something like a CBC. So do you know in your state, in your hospital, is it legal for you to test without the patient's consent? What if your patient's a minor? What if it's a 16, 17-year-old and a positive pregnancy test turns up? Are you allowed to tell this minor's parents? Are you going to cancel the case if they refuse testing or your surgeon's on board? They understand that they're not going to get their surgery done if this test comes back positive. And is it ethical, if you want to just look at ethical principles, to test an entire class of patient, meaning all females, just to protect the provider, us, from liability? And finally, how would your anesthetic change? We don't have any anesthetics that we know are teratogenic or cause problems with a pregnancy, so it's hard to make a case that the testing is medically indicated versus a liability risk. Now, just this last year, a surgical group took the NSQIP database and looked at 2,500 pregnant women who had surgery, compared them to a propensity matched group, and you can see the results here. There were more emergencies in the pregnant group because we don't go willy-nilly off doing surgery on pregnant women if we can help it, but there was no difference in maternal mortality and no difference in morbidity in the pregnant group. So medically, for the mother, there does not seem to be increased risk. This is what the ASA Practice Advisory on Pre-Anesthesia Evaluation says about pregnancy testing. The task force recognizes patients may present for anesthesia with early undetected pregnancy. She doesn't know yet that she's pregnant. Pregnancy testing may be offered to female patients of childbearing age and for whom the result would alter the patient's management. So if you have to go ahead with the surgery anyway, it's kind of a moot point. And they're not saying you must or mandating pregnancy testing, simply that you should offer it. Now here's a new problem that's come up. We're all transitioning over to electronic medical records, and most of them have a cut and paste feature. So in this case, a woman presented for a D&C due to a history of heavy menstrual bleeding. Her pre-op pregnancy test was reportedly negative, but at the time of her D&C, an 8-week pregnancy was discovered, and this was a much wanted, much desired pregnancy. It was later discovered that her preoperative assessment was populated with a previous negative test from another visit, rather than the current positive pregnancy test. So another thing that could potentially get us into trouble if you order a test, to be sure that you're seeing the actual current results. Okay, controversy number 2. Are there any anesthetic drugs that we should not be using on a pregnant patient that are not safe to use during pregnancy? Well, here's your case. You've got a woman who's 12 weeks gestation. She's going to have general anesthesia for a cervical cerclage placement that's scheduled to be about a 20-minute case. She is very anxious. She's had multiple prior pregnancy losses, so she's very nervous about this procedure, and she asks you if she can have preoperative sedation. So, according to ACOG, this is a list of known teratogenic drugs that pregnant patients should not be exposed to. And as you just eyeball up and down that list, do you see a single anesthetic agent on there, a single thing that we would be using in the operating room? No. Problem is, though, nobody studies pregnant women, right? Big liability risk there for the drug manufacturers. So we don't really have a lot of evidence-based data to treat pregnant women when they have an illness during pregnancy. And this study looked at industry-sponsored trials and found that only 1% of them were designed for pregnant women. And in the phase 4 clinical trials, 95% of them excluded pregnant women. So we really need some kind of thoughtful criteria so that we can get better information about what drugs are safest or best to use for our pregnant patients. We don't really have much of that at this point. But I think if you ask most anesthesia providers, well, what's the one drug you really wouldn't want to give a pregnant woman? They'd say midazolam or benzodiazepines in some form or fashion. And that came out of a couple studies that were published in 1975, so a long way back there now. And they were really anecdotal. Hey, we seem to notice this association kind of reports, but it was between benzodiazepines, and think about which ones we had in 1975. It was Librium primarily, Valium was fairly new, and cleft lip or palate. So that's the specific anomaly, is cleft lip or palate. But several other studies have been done since then that did not find any such association. And I think the first thing you need to ask yourself is, why were pregnant women taking Librium and Valium? Well, if you go back and look, a lot of these were polypharmacy. They were on it for alcohol withdrawal. They were, there was a whole multitude of confounding factors that went into that. But this study, for example, looked at 611 infants that had a cleft lip and or palate. Controls, no difference between the groups. You can see the risk of clefts was no different. Confidence interval crosses 1 for the combination or for cleft palate alone. Same thing here, this was an NIH prospective study, did not find any increased risk of cleft anomalies associated with diazepam use. In this more recent meta-analysis, looked at 7 cohort studies similar to the 2 I just showed you. Over 1,000 infants who were exposed to benzodiazepines, no increased risk of major malformations, and specifically cleft lip or cleft palate. You can see again the confidence interval crosses 1. So their conclusion was, even when the worst case scenario is assumed, benzodiazepines do not seem to be major human teratogens. And interestingly, if you go to the ACOG website, they have this clinical expert series on teratogenicity where they have a whole catalog of every drug you can think of. And this is a section on anxiolytics or benzodiazepines. It says there's no evidence of significant risk of teratogenicity. Initial findings of clefts have not been confirmed. Overall results are reassuring. And they conclude by saying it may actually be a beneficial adjunct for women with hyperemesis. So first trimester women who are having excessive morning sickness, nausea, and vomiting, they're actually recommending they get benzodiazepines to help with their treatment. And the other drug might be nitrous oxide. That's one you'll hear discussed, not just for labor analgesia like we did this morning, but also should you be using that as part of a general anesthetic. This is the largest study of exposure to nitrous oxide during surgery. They compared over 5,000 women having surgery with a cohort group that did not. And you can see over half had a general anesthetic. Almost all of those had nitrous oxide as part of their general anesthetic, and there was no difference in stillbirth or anomalies. There were increases in IUGR, but that was seen across the board for any woman who had surgery while she was pregnant. And then more recently, this was from the Nurses' Health Study. They looked at self-reported occupational exposure of nurses. 10% had a miscarriage before 20 weeks. The exposures that doubled the risk of a miscarriage had nothing to do with anesthesia, and there was no association of either early or late miscarriage with radiation or with anesthesia gases. So again, more reassurance that those exposures, even early in pregnancy, are probably not harmful in any way we know of. I mentioned ondansetron just because there's a lot of back and forth in the news media lately about whether ondansetron is a safe drug to use, and of course we give it out like water, but this was from a Danish database, looked at fetal outcomes, and did not find any relationship with stillborn, miscarriage, birth defects, preterm delivery, small size. And again, this is very commonly used by obstetricians during first trimester to treat women who have excessive morning sickness or hyperemesis. Okay, controversy number 3. When and how should we be using fetal monitoring when we take care of a pregnant woman for surgery? And I'm going to show you 3 different cases that kind of bring up various points about fetal monitoring itself. One's a cholecystectomy at 34 weeks, one's an emergency femoral thrombectomy at 31 weeks, and one is a series of 5 ECTs for severe depression. So first off, what do we normally do for monitoring when we take care of a pregnant patient in the operating room? Well, we're going to try to keep her blood pressure at least at her baseline, maybe a little above. We're going to do appropriate oxygenation, keep her CO2 down a little. We're going to avoid hyperthermia because a developing fetal brain does not like being heated, and so we're going to keep her temperature normal. Might get a blood glucose if it's a long case because she has a high metabolic rate. And then we're going to at least think about fetal heart rate monitoring if she is viable, either doing it intermittently or continuously if we possibly can. Less than viability, less than 24 weeks, probably we're just going to get fetal heart tones in the pre-op area and again in the PACU. Now, I want to make the case that fetal monitoring is something we should think about as a medical issue, not a medical legal issue. I want to stay out of trouble, I don't want to get into trouble, but a medical issue. Is it going to make our patient safer while she has this surgery? Now, I think you can make a case that monitoring is going to help you assess what's going on with placental perfusion and assuring the intrauterine environment is optimized. If you're going to have her in some weird position, if you need to drop her blood pressure, if you have a lot of fluid shifts or blood loss going on, yeah, it might give you a lot of good information as a monitor. But fetal heart rate monitoring is horribly imprecise. We've all done stat sections for distress with a 9-10 Apgar screaming, crying baby. It does require additional L&D personnel, which can be a hassle to arrange, getting a nurse to come down to the OR with you. We have 0 outcome studies to show that fetal monitoring makes any difference in the outcome of this pregnancy or this baby. Now, I will say that it does provide an important reassurance for the mother. So when I was 22 weeks pregnant with my daughter, my first, I did the Colorado thing and went tumbling down a mountain and tore my ACL. So I had my ACL repaired with an epidural. And it was very nice that every now and then, every 10, 15 minutes, we just plopped the monitor on, there she was chugging away, and then we'd go back to surgery again. And that was a nice reassurance for me, even doing what I do every day. So let's go back to our 3 cases. So this is the first one. You have a woman who's she's 34 weeks gestation. She needs a semi-urgent cholecystectomy for recurrent acute cholecystitis. Now, during skin prep, so before anything has been done to her other than going to sleep and prepping her skin, there's a severe persistent fetal bradycardia, does not come up with any of the usual maneuvers. So the obstetricians run in the room, they do a stat section, and she's got a true knot in her cord. Gases were horrible, APGAR scores were horrible till the resuscitation went on. This was a save, okay? This is a woman who would have walked into your triage area at term with an IUFD, a fetal demise. Fetal monitoring just happened to be being done, so that was pure luck and happenstance, if you will. Second case for fetal monitoring, 30 weeks gestation. Woman gets pneumonia during her pregnancy and ends up being on bed rest for about 2 weeks. So she turns up with a cold blue foot and needs an emergent femoral thrombectomy. So she's put to sleep for that. During surgery, the fetal monitor showed an absolutely flat strip, something looking like that. So this baby has no variability, absolutely flat. So after obstetricians running in the room again and some consultation, they decide this just doesn't look good. We need to deliver this baby. So they do. Baby's absolutely fine, normal pH, just sound asleep. But because she's 30 weeks, has to go to the NICU for an extended number of weeks because she's preterm and has not had steroids and all the usual preparation. So fetal heart rate monitoring definitely did not help us at this point. And again, that's what a baby looks like when it's sound asleep and has general anesthetic agents on board. Third case, so this was a woman who had medically unresponsive severe depression. So she's going to have a series of 5 ECTs. First ones are done between 17 and 19 weeks gestation. They get heart tones before and after. Baby looks great. The last one, they say, well, gosh, she's far enough along now. We should do continuous monitoring. And then stand there in horror as this baby decels down, had bradycardia. What are you going to do? She's 19 weeks. Can't really intervene. So they didn't do anything. And she went on to deliver a completely normal, healthy baby at 38 weeks gestation. So again, I think when you're thinking about fetal heart rate monitoring, you have to say, is this going to help me? Is this going to be reassuring? Am I going to intervene? How am I going to use this additional monitor that I'm thinking about? So what should you do if you are monitoring the baby and you see this intra-op distress while she's having, I don't know, her femur fracture fixed, for example? Well, you're going to do all the things you would on labor and delivery when you have a decel. You're going to up her FiO2 and her blood pressure. You're going to increase her left uterine displacement or tilt her to the right. If the surgeons have their hands down pressing on her belly, you're going to get them and their retractors out of the way in case they're causing aortic cable compression. You might give a tocolytic if you think she's starting to contract and you're seeing variable decels for that. You're certainly going to document your efforts in the records. Did you do what a prudent person would be doing when you saw this on the monitor? So for most cases, I think pre-op, post-op fetal heart rate monitoring is adequate, but you should consult with the obstetrician and always remember that loss of beat-to-beat variability is normal during a general anesthetic. Controversy number 4, should pregnant patients who have a viable fetus, so we'll say over 24 weeks gestation, have surgery in a specialty hospital that does not have any L&D coverage? So in other words, they don't have fetal monitoring capabilities, they can't do a C-section there, they don't have neonatologists in the house to resuscitate a baby anyway. So here's your case. You've got a woman, 28 weeks gestation. She was evaluated for deteriorating vision, and what was found was she had a rapidly growing meningioma. And so an urgent craniotomy was proposed to preserve her sight. Now at this institution, they had a freestanding neurosurgical hospital, and that's where the neurosurgeons lived, and that's where their equipment was, and that's where their nurses were, and that's where everything was done. The ICU was set up for neuro patients, et cetera. So the surgery proceeded, no fetal monitoring, no provision for a cesarean delivery because that was the best case to do a neurosurgical case. Well, ASA and ACOG have a joint statement on non-obstetric surgery during pregnancy. And one of the things it says is that surgery should be done at an institution with neonatal and pediatric services. An OB provider with cesarean delivery privileges should be readily available. Qualified individuals should be readily available to interpret the fetal heart rate. And again, an obstetric care provider with privileges at that institution should be involved. So ACOG would step in and say, no, you should absolutely not do that case there. I think most of us have been put in that position where maybe it's an ambulatory surgery center doing a pregnant case, for example. You have to make a judgment call. And last controversy is there some best anesthetic that we should be using during pregnancy to protect the fetal brain from neurotoxicity? We've kind of alluded to that in some other talks. In other words, do anesthetic drugs cause developing neurons to commit suicide or apoptosis? So here's your case. You've got a healthy, very well-educated woman who needs an emergency appendectomy at 26 weeks gestation. So she did a quick search on the internet before she came into the emergency room, and she's now questioning you about the effect of your general anesthetics on her fetus's developing brain. What are you going to tell her? So just a few months ago, there was an update in the New England Journal of Medicine from the FDA and Smart Tots, which are funding most of the neurotoxicity research right now. And they say there's a consensus that surgical procedures performed under anesthesia should be avoided in children under 3 years of age unless the situation is urgent or potentially harmful if not attended to, and making the point that virtually all anesthetic agents have been shown to have neurotoxic effects with the possible exception of dexmedetomidine. So what about the fetus in utero? That's not our pediatric patient that most of these studies are talking about. We know that animal exposure, you can see neuronal cell death and behavioral abnormalities. Is that the same for humans? We're really trying very hard to get a handle on that. We don't know. But we do know that our non-obstetric surgeries and our fetal interventions that Mark's going to talk about often use general anesthesia at high concentrations for longer than a typical C-section, for example. And we know that all of our lipophilic anesthetics can be measured in the fetal brain. They do get to the fetus. And in second trimester, which is when we try to do most surgeries if we can, there is rapid fetal brain development going on. So this was an editorial from a different study, but it says, well, it's not clear which anesthetic technique might be least toxic for the pregnant woman having surgery, nor has any general anesthetic been convincingly shown to be more toxic. Certainly, non-urgent surgery should continue to be postponed till after pregnancy, and consideration should be made to using regional anesthesia whenever possible. Okay, well, is regional better? This was a retrospective study that looked at adnexal masses discovered during pregnancy that needed to be operated on for diagnostic or treatment procedures. And they were roughly half and half that had general or regional anesthesia. Overall incidence of preterm labor was higher in the surgery group, no big surprise there. But the regional anesthesia group had significantly higher incidence of preterm labor, 30%, than the general. So if we're trading off neurotoxicity, which is a theoretical concern, with preterm labor and delivery of a 24-week baby, which is a very real concern, have we made any progress there? So I don't think you can just say, oh, well, let's use regional and everything will be fine. So in summary, I would say I think the way to go is to approach the surgical patient with respect, not just apprehension, and recognize that she is afraid too. She is worried about her pregnancy. And doing what's best for the mother will almost always be best for the fetus and for the outcome of the pregnancy. Now, I just want to mention again that ASA and ACOG have this joint statement on surgery during pregnancy. And these are the main points that they include. They want you to get a consult from the OB group preoperatively, hopefully the group that's taking care of her, and they should be readily available. They should be aware. I'll just tell you an anecdote. We had our urologist schedule a case for ureteral stent in the main operating room. The patient arrives in pre-op and she's 38 weeks pregnant, and her renal colic is coming every 3 minutes on a very regular basis. And so finally one of the pre-op nurses kind of dawns on it what's going on here, and so she gets whisked upstairs to labor and delivery and has a baby instead of a stent about 5 hours later. So again, an obstetrician really needs to be involved. They make the point that no anesthetic agents are teratogenic. Fetal monitoring might assist in positioning and cardiorespiratory management and delivery options. That you should perform the surgery where there are obstetric and pediatric services to handle a delivery. Pre-op and post-op fetal heart rate is adequate if it's a pre-viable pregnancy. If you are going to use continuous fetal heart rate monitoring, you need a qualified individual in the operating room looking at it for interpretation. And finally, a pregnant woman should never be denied an indicated surgery, but you should postpone elective procedures until after delivery, and if it's not urgent, try to get at least to second trimester. So I think this can be a really useful document when you're negotiating these things in the operating room with your surgeons and potentially with your obstetricians. So I'll stop there, and thank you very much.